Welcome, everybody. This is the VCU Department of Internal Medicine Grand Rounds. Today is April 25th, 2024. Just a reminder for everybody who's online also that we are on the second floor of Sanger Hall. If folks want to continue, we end this year on June 13th, so we've got about 6 or 7 Grand Rounds left until then. So feel free to come down if you want to join us. Today's Grand Rounds is one of our special Grand Rounds every year. We have 3 to 4 of these every year, a quality improvement or a morbidity, mortality, and improvement conference. So to get us started and introduce our speakers, I'm going to invite up Dr. Stephen Biederman. Dr. Biederman is the Associate Chair for Quality and Safety within the Department of Internal Medicine, to introduce our speakers and get us started. Dr. Biederman.
Thank you. It's my pleasure to introduce our 3 speakers for today. First is Dr. Georgia McIntosh. She is a hospitalist and currently serves as the Interim Chief Quality and Safety Officer for VCU Health. She was recently named to the Gene Peterson, MD Professorship in Safety, Quality, and Service. She has long been a champion for merging quality improvement and patient safety principles with medical education and interprofessional collaboration. She has worked to further this mission by leading, teaching, and collaborating on numerous quality initiatives, both locally and nationally. Next is Dr. Evan Metters, who is an academic hospitalist and assistant professor of medicine, as well as a fellow of the American College of Physicians and the Society of Hospital Medicine. He received his degree at the Medical University of South Carolina and completed residency here at VCU, where he then joined hospital medicine as faculty for the past 16 years, and has been active in medical education as a longstanding instructor for the Practice of Clinical Medicine course. He also has a focused interest in medical documentation and has served in the role of Medical Director for Clinical Documentation Improvement for Internal Medicine, as well as serving as a member of the Medical Records and Utilization Management Committees for the health system. And finally, we have Irene Zolotorofe, who is the VCU Health Director of Care Coordination. She's been a registered nurse for 32 years, and her focus for the last 15 years has been in leadership, leading teams and departments in population health, ambulatory nursing and primary care, care management, utilization management, and social work services. She received a Bachelor's of Science in Education from SUNY Old Westbury College, a Master's in Science at Hofstra University with a focus on mental health, and a Master's of Nursing here at VCU. She has published in various nursing journals such as the Journal of Nursing Administration and the American Academy of Ambulatory Care Nursing. Ms. Zolotorofe is passionate about working with patients and their families who experience complex medical and mental health needs, and has worked with patients across their lifespan, ensuring needs are met across the care continuum. So thank you, all 3 of you, and look forward to this talk.
All right. Well, thank you, Steve. And I have to say that this slide is incomplete because these really impressive folks that are with me are not included on this slide. So I'm going to advance. Thank you everybody for joining. This is our quarterly morbidity, mortality, and improvement conference. We are titling this Make It Count Twice, Driving Quality Metrics in Your Favor. And the reason that we're doing this is that oftentimes we do a lot of this work and we do it because of our patients. We want to ensure that our patients are getting the care that we know is right and good for them. But sometimes we don't always tell the story in the way that it would be transmitted to external bodies. And so how do we get that credit for really doing this really important work, but also having it count for those external agencies? Steve introduced the folks that are presenting with me. So I'm going to go forward and just give you a little bit of the background. So normally, our MMI conference is focused on one case where maybe there was a deviation in generally accepted standard practice. And this is not the case for this session. That really we're going to be talking about organizational improvement efforts. So it's not necessarily driven by an error or a serious safety event, but really focused on kind of where we anchor our information in terms of our metrics and how do those metrics guide us in terms of improvement efforts. So the objectives for today We're going to talk about performance benchmarks in terms of some of those large quality reporting entities. We'll speak about our current approach with readmissions and specifically how those reporting agencies kind of help to guide us in terms of some of the work that we're doing with readmissions. And then the third piece is you will identify ways that you can help to influence our mortality performance. And I want to make sure that I state this, that when we talk about our mortality, and we'll speak about where we stand compared to other academic medical centers, the care that we provide is really stellar. It's really the way that we tell the story that makes us change in terms of how we are rated. So how do we tell the story in a way that really gets us that credit? And we have no conflicts of interest to disclose. All right, so to start with. So we have a lot of folks that, of course, are interested in our quality metrics, our stakeholders, the folks that really care about what we are doing and how do we tell that story. So, of course, our patients and our families are interested in our what we do. And within that, our providers, our bedside providers, our executives, our administrators, they all want to know, how are we performing? But we also have some external folks and entities that really help to drive a lot of that performance and level set how we are performing based on other reporting agencies. So we have these value-based and pay for performance programs that give us some direction, both for incentives in terms of how we perform, but also some penalties if we don't meet certain metrics. You know, entities like our CMS hospital inpatient quality performance programs or outpatient quality performance programs or healthcare associated infections or conditions, all of those help to drive what our performance is and really helps us to perform in different ways. And I'm not going to speak necessarily too much about the value-based and pay for performance programs. What I will speak about is our external ratings and rankings program. So talk a bit about CMS, a bit about other entities which you may or may not have heard of. So how do we integrate with Vizient? How does US News and World Report help to drive some of our work? How does Leapfrog help to drive some of our work? And how can we align the work so that it gets us the most credit, so to speak, for a lot of the work that we do? So that's really, it's that external ratings and rankings that I'm going to spend the most time on. So there's, of course, areas that have a lot of overlap. And I think that's understanding and recognizing where overlap lies helps us to kind of get credit multiple times. So all of them have different metrics and definitions, which just makes it a little bit more complicated and challenging to align our work. But I think that we have some areas that give us a direction for the most part. So starting with CMS. So for everybody, I think everybody recognizes the Center for Medicare and Medicaid Services. It really helps us to ground what we do in terms of our performance. CMS uses 47 different metrics that help to state how we're doing with quality care. And this is within 5 different domains of quality. So readmissions, mortality, patient experience, safety, and timely and effective care. So those 47 metrics feed into those 5 categories. The CMS rates hospitals in terms of their performance with a star rating, a 5-star rating program, so anywhere from 1 to 5 stars. And just to give a little bit of information, about 10% of hospitals achieve a 5-star rating, about 10% achieve a 4-star rating. So it is not in a large group that either you're in that top or that, that 4-star rating. VCU in 2019 achieved a 2-star rating, then in 2020, a 3-star, and then in 2023, a 4-star rating. So we are currently at a 4-star rating. So we have that 5-star rating in our sites. The things that will likely get us to that next point are our patient experience scores, as well as our hospital acquired conditions. It may be challenging because we are a safety net hospital to achieve that 5-star rating, but that doesn't mean that we should not aim for that. I think that that is at least a good guiding principle in terms of what every hospital really looks towards. So to pivot, we participated in Vizient. So just to spend a little bit of time on the Vizient information. So Vizient, what is Vizient? It's a kind of a conglomerate that uses a number of different domains, 6 different domains of quality, to really help medical centers, and specifically also academic medical centers, to compare their quality performance in those 6 domains. We have information for both the inpatient as well as for ambulatory, and I'm going to spend most of my time really speaking about inpatient quality domains. The different domains each get rated differently, so there's a different score with each of them, and I'll speak a little bit about that and show you how VCU is performing currently. But it's a great way to compare our performance to other comprehensive academic medical centers. About 98% of CAMs actually use Vizient to compare their performance and their scores. So it's a pretty robust way to look at what our performance is with quality and safety. So other entities that really get people's attention and help us to really talk about and show what our performance is. So Leapfrog is one of those that you probably have heard of. Leapfrog helps us to show our performance based on a grade, so A, B, C. Leapfrog has 2 different ways that it collects data. For the most part, the data comes from CMS, but some of it comes from the American Hospital Association. There is a way that the data gets just submitted through Leapfrog for just baseline data, and that is primarily related to safety. There's also a voluntary survey that healthcare systems can participate with, and this is often twice a year, so in the spring and in the fall. And that's where the score really comes into play. The Leapfrog safety grade is based on 9 different big quality or big categories, and for the most part, they focus on safety. So how does your nurse staffing ratio look like? What does your EHR look like in terms of CPOE? What does your medication safety program look like? What does your safety program look like? And do you learn from near misses and serious safety events? So Leapfrog focuses mainly on safety based on those 79 different metrics in those 9 categories of care. The survey itself is over 300 pages, which I've actually downloaded and read through. So it's multiple different questions. For VCU, we actually participated in that voluntary survey in 2014. And at that time, we earned a C grade. So we currently are investigating whether we can submit and get a better grade. And likely we should be able to get a better grade for a current submission. But this is, of course, the part of the benefit is that it gets eyes for our patients and for our community, but again, really helps to tell our story. And then US News and World Report looks at our performance, but mainly regarding processes of care and mortality. That's one of the biggest areas that US News uses to score different healthcare systems. So US News uses 200 different metrics and mainly focuses on service line. So cardiology, oncology, rheumatology. So it uses those 15 different service lines, uses data, again, for the most part, looking at mortality. There are 3 service lines where they don't have enough data, and so it's based on expert opinion. So that's ophthalmology, rheumatology, and psych. But otherwise, it really uses like 30-day mortality and patient experience to help grade hospitals with US News and World Report. So we have all of these different categories and metrics that all of these systems use, but for the most part, they all use the kind of classic mortality, readmissions, hospital-acquired infections, complications, and patient satisfaction. So part of our job is to see where can we align a lot of our work so that we can get as best as possible good scores from both CMS, from Leapfrog, and US News and World Report. And from what we can tell, mortality and readmissions is the unifying factor that fits that Venn diagram that we can really focus on that helps to boost our scores in all 3 of those metrics. So I'm going to speak a little bit about that. So first of all, this is our Vizient quality and accountability scorecard. This is related to our inpatient quality of care. So just to give you a little bit of orientation for this data, this is looks at those 6 domains of care. So mortality, equity, patient-centeredness, effectiveness, safety, and efficiency. And each of those domains is weighted a little bit differently, but altogether they contribute to how our hospital fares compared to other academic medical centers. So we currently have a rank of 39 out of 116 medical centers, and that gives us a score of 56%. On the right-hand side is a list of some of the top hospital performers. And for the most part, their rank is, their percent score overall is in the 70-something%. So NYU, Rush, Mayo Clinic are the top 3 that we are compared to, and they're all 79, 75, 73%. So nobody is, at that 90 or 100%. And it gives us a good kind of comparison for what other academic medical centers are scoring with those quality metrics. On the bottom right of the slide is our overall performance with this Vizient Quality and Accountability Scorecard. And this is over the past 18 years. So lower is better in terms of that overall rank. Our current rank, as I said, is 39. So that's actually the best that we've done in the past 5 years or so. So we want to, of course, continue to get better, but it gives us a rank in terms of what our own performance has been over time. And then if you're interested in terms of the performance for those 6 domains of care, that is that table on the bottom. So one thing that I have to make sure that I identify is that our safety is actually number 1. We actually are performing number 1 in all of these 116 comprehensive academic medical centers regarding safety. And this is specifically with hospital-acquired conditions. So identifying if somebody has a pressure ulcer before admission? Or how are we doing with ensuring that if there's a CAUTI or a CLABSI, that those are identified appropriately? So a lot of that work is actually with our group that looks at each of those cases to ensure that we're actually specifically and correctly identifying those hospital-acquired infections or conditions. So we are doing great for that safety aspect. But we see that there are other places that we have opportunity to continue to improve, and that's where I'll spend a little bit of time talking about. And so this, again, just gives us a little bit of comparison for our overall distribution for other CAMs. We're 39th out of 116. So 3-star, we're close to that 4-star rating, but that's currently where we are. So as I said before, we can tell from our Vizient performance that mortality and effectiveness, and within effectiveness is readmissions, are areas that we likely have the biggest opportunity for continued improvement. As you can see, mortality in that total score compromises 25%, and we are only achieving 11, almost 12% of what that score could show or could gain us for mortality. And then for effectiveness, within that is readmissions, that we're only achieving 9% of that total 20% of that score. So those are large areas and areas that we likely need persistent and improved effort. So for the mortality, this actually gives us our Q4 of 2023 performance. Just to orient you, the blue side of the graph is where we want to be, and the red is where we don't want to be. And that blue line all the way towards the right side is where our current, or where our Q4 2023 performance is. So definitely room for improvement. Again, I don't think that the care that we are providing is poor. It's that we're not documenting in the way that really gets us the credit for all the work that we're doing. So when we look a little bit further into our, and this is for our entire healthcare system, not just for the Department of Medicine, this is in aggregate. But when we look at our mortality O to E, we see some more information in terms of where we may be able to focus our efforts. So just for orientation, that observed to expected ratio is what we really look at in terms of helping to show what our performance is. The observed, of course, is the patients that actually pass away. And the expected is what is expected based on that the demographics of that patient, so their age, their comorbidities, their gender, within that same time frame. So a lower, less than 1 O to E is the objective, is really to say that we identify more patients that have an expected mortality than what we actually see. And so that really, again, goes into how do we document and document conditions as accurately as possible. We likely are not going to affect the folks that have that above or well above expected mortality, because those are the folks that are really sick. Those are the folks that we know that we want to get here, because as a quaternary medical center that we can have the subspecialists and subspecialists to care for them. But patients that perhaps are in that well below and below expected risk of mortality, that maybe there are opportunities to amend our documentation so that we can capture any complexities and really increase potentially what the expected risk of mortality is and drive those numbers down. And then for effectiveness, this again is that comparison, the how we perform compared to our other performers. The top performer is in that 79%, and higher is better, and we are at that 51%. So opportunities to continue. And just to give you a sense of how we've done over the past 3 years, so we've been in the 40-ish% for the past few years. So that's the Vizient data. Our CMS data gives us a little bit similar information, but more specific towards conditions, so DRGs. So as I mentioned before, CMS looks at 5 different categories of care. And specifically, we're just going to talk about mortality and readmissions. The right-hand side of that graph is that cake layer that shows us kind of the areas that are not ideal. That's in that pink red section. That's where we don't want to be, all the way to the green, which is good performance. And so when we look at mortality and readmissions, we see more of the graph towards that red section, the areas that we know that we have some areas for improvement. So, and it's not all across the board, but we do have some areas that are identified in CMS. So for instance, death rate for patients that have COPD are in that red area, or death rate for patients that have had a stroke, again, identified just with CMS, are areas that we likely have some areas for improvement. And then for readmissions, we see a number of areas in that orange and red area that, again, show us that we have some continued areas for improvement. So it helps us to say that both CMS and Vizient give us the same information that this is where we should focus. So we don't have a lot of robust data for US News and World Report, but again, I think that there's opportunity to align this work so that we can get credit here as well. Our PEDS CHOR has been on this journey and have been able to show really good performance in 8 different specialties for pediatrics. And so focusing on the adult medical center is we have some opportunity there. Currently, we're ranked number 2 in the state of Virginia, number 1 in Richmond, but likely that some of this work will also influence our rating with US News and World Report. And as I said before, a lot of this data focuses on outcomes. Their scoring system is a little bit opaque, to be honest, but when we look at the things that contribute the most, patient outcomes, and specifically 30-day mortality, is where US News and World Report puts a lot of that focus. So we think that focusing on that mortality and readmissions is with that performance. And then just a different way of seeing our current performance are on the left is our inpatient mortality. Again, this is for the medical center, not just for the Department of Medicine, but this is for our year-to-date performance. That our OTE is 0.96. We'd like it to be lower, closer to that target that was set in 2023 of 0.83. So opportunity, definitely room for continued improvement. And then on the right side is our 30-day and our 7-day readmission rate. We are starting to see some improvement towards where we want to be, but continued work. So at this point, I'm going to turn it over to, before I turn it over to Irene, just going to leave you with one slide. It's a busy slide, but it helps us to know what the time frame is for all of these reporting agencies, that it takes a long time. So for instance, when we are looking at our CMS 5-star performance, it takes about 3 to 4 years in order to move that star rating. Vizient is the quickest, so we get that increase of scoring over year to year. But really, for things like Leapfrog or US News and World Report, the things that we're doing now are going to affect our performance and our star rating, or our A, B, or C rating for Leapfrog in 4 or more years. So it's really a marathon. It's not a sprint, but we know that it's the right thing to do. So I'm going to turn it over now to Irene, who's going to speak a little bit about our readmissions.
Thank you. Great. All right, so we are going to go over readmissions and what are we working on and what are we doing now. I partner with Dr. McIntosh on this for the last couple of years. I think you've all seen the data in Dr. McIntosh's last slide. What we're going to talk a little bit about right now is really risk level when the patients are leaving the hospital. So right now we do have a score when the patient leaves the hospital that kind of helps us to understand the trajectory of that patient's path when they're leaving the hospital. And what we know from long studies is that our providers actually know the best when a patient is going to be readmitted. So your prediction is better than any predictive tool that we have, where you guys are close to 80 and 90%. Predictive tools are less than that, but they have come a long way. And this helps guide other team members to know kind of what is happening, which you know internally and are on your internal radars. So that's important that we recognize that. So how does the rest of the team understand that? So when we look at our readmission risk scores, we do know that, and I'll just talk through this a little bit, you know, our patients, and I'll show you this, some of the data again, our very high risk patients are the patients that get readmitted the most, right? So they get readmitted at a rate of 1 in 3. So if you see a very high risk score, we're going to say that that patient is 1 in 3. The other thing about that patient population is they're 7% likely at VCU within our own data to die, you know, close to that admission. So that's important that we know that. And so when we think about the interventions that we're looking at for that patient population, that'll drive some of your discussion with your patients and their families around end of life care and working through that conversation with them. Our high-risk patients that you're seeing there, they readmit in 1 in 5. So when you see that score, it helps our staff to say, okay, this patient is likely going to be readmitting. So let me think about what am I going to do there. Our medium score is about 1 in 10, so a little bit more time, and we're seeing better there. And then, of course, our low-risk patients are not really readmitting that frequent. Okay. And this is just another way to look at the data. And so it's just really showing you overall that the highest opportunity that we have when patients are leaving the hospital is really when they're first leaving the hospital. And then it kind of goes down from that point. Okay. And we, of course, care about when they're leaving the hospital directly, because we're setting them up for success as they leave. I think you're aware of this. Dr. McIntosh does a beautiful job talking to us about data. Okay, so what are some new data points that we're discovering about our patients, right? And innately, you already know this, but we're actually going to call it out with data, is that our population that have social needs, and we're, you know, see right now, Joint Commission is saying to us, hey, we got to collect information on social determinants. It's a new Joint Commission regulation. So we've been doing that and preparing for that for about 2 years. So we have good data around our social determinants. And now we're working with Cheryl Garland and her team on what are we doing with that population and how do we support them. But what I want to point out to you is that the rate at which our patients are readmitting with a higher social need. So that's why partners with us in care coordination and social work is going to be pretty important, and with Cheryl Garland's team, because we are seeing those patients readmit at a higher rate. If you take out the social determinant, we're kind of close to where we want to be from a readmission score. So that population needs a little bit of special focus because we know they're coming in more frequently. And I know you guys know that. All right. So what are we doing? There's no secret sauce to this. It's kind of a culmination of activity that not one thing fits all. So we have to be pretty vigilant on how we're thinking about our patients. If you look at our knee, if you saw the orthopedics score, when you talk to them about their secret sauce and what they're doing for knees and hips, elective procedures, is they're trying to optimize their patients before they come into the hospital. So if their blood sugar is high, they want to get that blood sugar down. If they're anemic, they want to make sure that they're dealing with that. If they're smoking, they want to tell their patients, yeah, no, we're not taking you to surgery if you're smoking, right? So those are things that when they're looking at their population, they're thinking about. You guys don't have that luxury because you're dealing with patients that have a lot of chronic illness. And then the multitude of chronic illness is going to create problems, for you guys. So what we're focusing on right now, if we focused on only one thing like sepsis, and we'll tell you a little bit about like the diseases that are coming back, but if we only focused on one thing, we wouldn't really move the dial. So our approach is to focus on a couple of things as we're going forward. So we know the patients that are coming back. So the very high and the higher risk patients, we want to have appointments for them before they leave the hospital. We want to make sure that we're kind of hand-holding those patients out the door and we're sticking by their side and we're not leaving them until we know that services are wrapped around them in the community. So that's one thing. And so our goal is really to make sure patients have appointments before they leave. And so we're going to be working with you guys on that. Another thing that we're doing right now, and I think you might have seen this, is we have a paper that kind of looks like a newspaper. And what this is really doing, for the patients and their families, and we're doing this in the North Tower, it's a pilot that we're doing, is just really kind of making sure there's something there for the patient that we're going over for the needs that they need when they're transitioning. And we'll talk a little bit about risk because we are talking to the patients about their risk for returning and why we need to get that support system in place before they leave the hospital, why they need those appointments before, and how can their families support us. So you got a couple of papers there. The other thing that we're doing is I'm channeling Dr. Bowling right now because Dr. Bowling would say, we got to talk to the PCP. We got to pick up the phone. We got to call them. And, until we do that, we're still going to be in trouble. So I am channeling him as I send that message out to everybody here. And so what's really important is, how do we continue with our most complex patients to make that handoff to them? And we got to find that way as a team. And so we're working through that. We've got nurse navigators that report to us. So one of the things that we've done from a service line perspective is we do have nurse navigators reporting to us. In the ambulatory world, we have social workers reporting to us. We have the insurance companies now coming into VCU so we can give tight handoffs to the next party that's going to pick up that patient. Really important, and you'll see this in a minute, is our advanced care planning, a strategy around our high-risk patients. I can't really say enough about that. And this is really just, starting the conversation. I know that we should probably be starting this in ambulatory and, kind of our path to that. But unfortunately, when the patients are in the hospital, we don't have a big primary care footprint. So unfortunately, tag you're it for some of these more complicated conversations because of the way that we are a specialty hospital. Again, I think the next thing, Dr. McIntosh, I'm sure will start talking about is, more disease-specific interventions at the service line. I think you saw, how can we talk to cabbage, oncology, a little bit more talking to medicine, as far as some of the things that we're doing there. And then just really, creating more and more resources in the community, for our patients to get to if we can't get them to primary care, right? And then focusing on the special needs population with social needs. But one of the most important things that, I wanted to say about our own providers here at VCU is that our SNF team, if you send a patient to a VCU partner in the SNF, they are rocking it. Their readmission rate is phenomenal. So you really want to make sure that we, really give kudos to our providers in the SNFs. Our patients that are getting readmitted are coming from home. Okay, so I just want you to know that that's where they're coming from. This is the document that we are working on, and we're giving families, and this little section right over there in the middle, it's talking to families about their risk and just knowing hey, we've got to get things more kind of firmed up before you leave because you have the potential for coming back into the hospital. So let's make sure everything is solidified. Okay. And this is what we're working on with our nurse navigators and our RNs in the hospital before they leave the hospital. So we're kind of working on what are we doing with them before they leave? And then what are they doing with them out in the community? So when we talked about that walkthrough with our care coordination team and our RN navigators, that's kind of what they're following to make sure that the patients are doing well. So we know when we talk about, I see Dr. Our heart failure leader here, when nurse navigators make phone calls and touch patients and they keep going, we prevent readmissions because we're able to block and tackle sometimes for providers in the community and help support them in getting patients where they need to go. And that's super important. The other thing about nurse navigators and care managers in the community is that our patients have direct lines to them. We give them our phone numbers. They can talk to us anytime they want to, and they can bypass the system when they can talk to an RN care coordinator or a nurse navigator. And then here's, our, this is an old slide, but a goodie slide. We want to see certainly advanced directives take place in our primary care offices and our specialty offices when patients are not in the hospital, and we start trying to having those conversations around when they're well, let's get an advanced care plan going. As disease sets on, we still kind of talk about that. But once they come into the hospital, and that's a lot of times where you are as a physician and medical team, is really then you guys, if they haven't had those discussions earlier, that's where we really need your support. Now we are training our team here to become experts at that. So you don't only have the palliative care team working on that, but you have your social workers, you have your pastoral care, you have your RN navigators that can also navigate that. And we're working on very specialized training for our ICU team members. So it's a partnership. And so I hope that was informative, and thanks for having me today. And we've left you some papers if you want to see what they look like.
Okay, so we'll kind of end our talk with a little bit more on mortality and documentation improvement. So Dr. McIntosh already mentioned a little bit about Vizient and what it is as an organization, how it compares comprehensive academic medical centers, and where we fit into that as a whole. She also brought up the theme of making it count twice, and that really holds true for documentation, in that as we document, we really have several goals in mind towards demonstrating risk of mortality, as well as a lot of other elements of complexity for our patients. So we all know that our patients are complex, but how do we quantify that effectively? So ultimately, we do this by having CDI professionals review our documentation so that we can confirm we have a good understanding of the diagnoses being treated, their acuity, what additional illnesses are they being treated for. And the way that this fits into an overall framework is using an MSDRG model. So MSDRG, for those of you that might not be familiar, is a Medicare Severity Diagnosis Related Group. It's a large framework of close to 1,000 different sort of variants, and it fits into kind of the primary diagnosis that people are being treated for. The Vizient risk adjustment that we use for mortality ultimately has a different model for each individual MSDRG that they apply. So it does more than that, though. So MSDRG is ultimately how we derive a lot of other relevant factors for inpatient revenue cycle and quality too. So that includes things like estimated length of stay and the associated resource intensity, and ultimately reimbursement as well. Mortality risk adjustment looks for present on admission diagnoses. And so that's important, and one of the reasons why we focus on identifying everything that's present when people come in the hospital, because that's ultimately how we get our comparison data for mortality risk. Notably, there are some other metrics that describe severity of illness and risk mortality using the APR-DRG system, but for Vizient mortality risk adjustment, we actually don't use that. It's more just these POA diagnoses. So based on the flow chart, we as providers document, the CDI team members review all of this, clarify if necessary, and then all of this goes into the Vizient risk adjustment, and we get a better sense for, as an aggregate, what are the risk of mortality for a patient population as a whole. There are a couple of other terms that I wanted to identify in terms of what other things get derived from our documentation. One of the big ones is the relative weight. So each individual MSDRG has an associated relative weight, which is really a quantification of resource intensity. And ultimately, on average, the relative weight for all of our rates our case mix index, which is one of the most important comparative factors that we share amongst different CAMCs, looking for just, well, what's the overall level of complexity of our patients as a whole, and how many resources are we using to take care of them? Many MSDRGs have 3 different sort of levels of relative weight based on if they have CCs or MCCs. So CCs are complications or comorbidities, and MCCs are major complications or comorbidities. And all of this is derived from documentation, and this is why being specific about diagnoses oftentimes really goes a long way towards making sure that we're describing this effectively. Geometric mean length of stay, how we ultimately get our length of stay index, is also derived from MSDRGs. And then finally, as we mentioned earlier in the talk, elements of quality such as patient safety indicators and hospital-acquired conditions, these are ultimately identified through documentation. And so it's critical that we be descriptive and accurate when we describe these things. So this slide is comparing a couple of these metrics in unison together. The top line in the gray here is a bar chart of our case mix index. This period covers all of January through the early portions of 2023. And what you'll notice, it varies some over time. And there's also a little bit of association between that, our expected mortality, and our expected length of stay. So the middle bar chart shows our expected mortality rate, and then the index, the orange circle graph, shows how this varies based on our observed versus expected. So again, this is a product of our actual mortality rate as well as the estimate of mortality that we derive through Vizient. And then lastly, on the bottom is our length of stay estimate. And so ultimately derived from MSDRGs, varies widely based on what specific diagnosis we identify as the primary one. And we get our index based on what the actual length of stay is for our patients. So another very relevant metric, especially for care coordination. So this is a graph showing CC-MCC capture rates, as well as our medical versus surgical case mix index. So the top line shows the percentage of our patients that have a CC or MCC identified. For top performers, this number is well into the high 70s. So we, in general, do a reasonably good job, but there's always room for improvement. And that's really one of the key focuses of CDI in doing this. The middle graph here is medical and surgical case distribution. So this is basically what proportion of patients fall into surgical DRGs at our hospital. So the ratio is relevant just because surgical patients and surgical DRGs as a whole are higher resource intensity. They just require more care, obviously, OR time, and many other factors that provide a higher relative weight for them. And so the bottom line here is our case mix index broken down into medical versus surgical DRGs and the CMIs associated with each, and then our case mix index as a whole. So a lot of data on this slide, but this is showing the top 20 MSDRGs that we actually treat at VCU. And so this is fairly reflective of our medicine patient population as well. So a couple of takeaways. There's many different MSDRGs. As an individual provider, the people that you're taking care of, it's not necessarily the case you'll know what DRG people fall into, nor is it really necessarily relevant on a clinical basis to know that. That's the jobs of case coordination, CDI, et cetera. What you'll note is that there's a high variance in relative weight based on what primary diagnosis they have. And so this changes a lot based on kind of the primary issue that is being treated. Some surgical DRGs, such as transplant patients, people that undergo ECMO, people that undergo tracheostomies, very high relative weight, and they contribute kind of an outsized factor to the case mix index. We, as medicine, take care of a very high volume of patients. And so relative weights are overall lower, but because it's such a large number, when they have CCs and MCCs, it's really important that we document that so we can show that actually these are still very complex patients that we're seeing. This is an example of a Bayesian risk model for 871 MSDRG, so sepsis, most common DRG, referencing that prior slide. The takeaway here is there's a lot of different diagnoses that factor into risk adjustment. As an individual provider, you will not be able to identify what's going to be most relevant, which is really part of the principle as to why just documenting thoroughly in terms of associated diagnoses, acuity, and complexity is critical towards really maximizing the demonstration of the risk of mortality for patients. So a little bit about provider queries. So all of you that practice inpatient medicine as attendings or APPs likely have gotten queries at some point to provide further clarity on a diagnosis or a POA status, a variety of different things. A lot of that is ultimately geared towards trying to best estimate our mortality for inpatients. So the graph here kind of demonstrates the proportion of queries that are really aimed specifically at mortality risk adjustment through the Vizient model. The green mountain chart here is the overall percentage of queries that are looking at a Vizient variable for a specific patient in that MSDRG associated risk model. And then the gray bar is sort of our total for month to month, and the dark blue is the total that are really looking specifically at those Vizient risk variables. So frequently, as much as a third of our queries are really looking towards that. And so, not only looking at other metrics such as CMI and things like that, but looking at mortality risk. So this shows query opportunities and sort of some of the big themes that appear in terms of the types of things that are very clinically meaningful towards risk adjustment, and also maybe opportunities for us to do a more thorough job documenting. What really stands out here is malnutrition is a huge chunk of the provider queries that people get, as well as abnormal labs and clinical significance. So what those things mean is simply where there's a lab abnormality or some other piece of data that's not described in diagnostic terms in the provider notes. And so really there's an opportunity to say, well, this is the specific condition associated with what we're seeing otherwise. So some similar information in a different way, just looking at, well, these are the kinds of things that actually contribute on a regular basis to mortality risk adjustment. So nutritional status clarification, heart failure acuity and type of respiratory failure, which we encounter for many of our inpatients. And then finally, something present on admission as well, just because, as I mentioned, risk adjustment for mortality is really looking for POA diagnoses. So this is just an example of the types of things that CDI does, looking at how clarification of a couple of different diagnoses may have just drastic effects on major metrics that we look at. So in this instance, a patient that comes in with pneumonia is described as having pneumonia without kind of additional clarification. And so that falls into an MSDRG 195, which is simple pneumonia without CC-MCC. You can see it has a specific associated length of stay estimate, a specific associated relative weight. If we, using our diagnostic reasoning, determine, well, this is actually an aspiration pneumonia and it's associated with acute on chronic systolic heart failure, an MCC, that puts us into a completely different DRG. So this is a respiratory infection with an MCC, actually almost triples the relative weight associated with that particular patient, doubles the estimated length of stay. So again, reflecting just how much more complex the treatment may be just based on those things that are ultimately things we identify clinically. So a couple of other principles. This is really tied to care coordination and looking at inpatients in observation patients that have short lengths of stay. On the left side is the top 10 diagnoses that get admitted to internal medicine services that are non-specific. They oftentimes are more like symptom-based rather than associated with a particular acute pathology that's more identifiable within a specific MSDRG model. So a lot of things are very appropriate for observation. So things like chest pain, nausea, vomiting, failure to thrive. These don't necessarily meet inpatient criteria in terms of resource intensity. And so in particular, if patients that have one of these conditions has a prolonged length of stay, so kind of passing that observation window, then that's really where we have to look at, are we being as descriptive as we can be about the primary diagnosis, or through study, have we identified other things going on? And then lastly, want to talk about Engage One for a minute. So many of you have gotten emails regarding Engage One. So this is a 3M Solventum product. So Solventum is a recent spinoff of 3M. 3M as a company has been doing a lot of CDI resources for hospitals for many years, and we've used 3M for many years as well. What this product is a software that adds on to what we already use, that provides better tools for physician queries, as well as eventually the implementation of natural language understanding to basically provide real-time prompts to us to be more specific in our documentation when possible. So circling back to some of those clinical opportunities on the pie chart, a lot of those things are things that through basic adjustments to our documentation can really in real time be more specifically described and may have a significant impact towards how we can most effectively document and by virtue of that describe our patient's complexity and risk best. And so I'll end just by referencing our partners with Solventum, Ensemble, which provides CDI resources both for hospital billing as well as our physician E&M billing. So we also have, for those that are interested, some cards, pocket cards that actually list out CCs and MCCs that we are most likely to encounter. So just things to have kind of front of mind as you're documenting what are the things that are going to be most impactful to make sure if they are present for our patients that we include in our notes.
Thank you so much. I was just going to pass some of these out, but there were one or two questions online. Looking at those, I'm not taking any questions from the audience here.
So from Dr. Selby Penzak, the Preference Bridge Clinic is available. So thank you, Dr. Selby Penzak. The Preference Bridge, from what I understand, helps with patients to speak towards their advanced care planning needs or preferences, and can be that adjunct, especially in the ambulatory setting for patients that have chronic medical conditions that may need help in terms of figuring out what their advanced care planning needs or opportunities are. So there's a question, can you elaborate on the inpatient chemotherapy administration? Do we have a list of those treatments that get us negative RAP on the scoring? I don't know about the specific list of chemotherapy agents, but definitely we can speak towards and we can get you information about how does that contribute to either the length of stay or the overall risk, and to make sure that we get accurate reimbursement for patients that need chemotherapy in the inpatient setting. And then the follow-up question, in many cases, we end up doing outpatient chemotherapy on the inpatient side when patients have adverse social determinants of health. Is there a way that this gets captured in scoring? That's another good question. I think for part of what we can all do is to help document as much as possible. So if somebody, and some of it is, of course, insurance specific, but as much as possible, if you can document the reason for the inpatient treatment and reasons that it will not be successful in the outpatient, that does help. You know, our job is to advocate for patients as much as possible while being financial stewards of our healthcare system. So part of this is, of course, understanding what insurance is looking for, but also what our patients need. But if you can be just really descriptive about what you think needs to happen in the inpatient setting and why it won't be successful outpatient, that will help.
I think in the future too, we are starting to communicate with the payers on our BOB bills about that this is a social determinant. So ultimately, that information will eventually get communicated, over to the CMS, because we're starting to do their social determinant capture. And then hopefully, as we continue to build, that information will flow over to CMS. So that's what our hope is, and that's what CMS is trying to do right now. Is because we have a need to capture it from a Joint Commission standpoint, but also from a CMS perspective. So that information is flowing in both locations right now. So it's not here today, but that is the goal, to communicate that eventually as they're looking at it, from the CMS standpoint.
Thanks. We probably one more question maybe in the audience. If anybody has anything, then we have to wrap up. Does have any last comments?
No, just if you want to take one of these cards, spread it to your friends, because it has those common comorbidities and major comorbidities that just using the terms that will again get us that credit for the complexity of the patients.
If those that are online wanted to pick one of these up, is there a place they could go?
Do we have the
I don't know if maybe for the residents or some other folks, I don't know.
we are working on a Teams page that folks can get access to this. So when that is ready, we will make sure that everybody knows to get that electronically. But in the meantime, before it's there, you can email me or Dr. Meadows.
And I'm assuming this discharge care plan document will be available on the floor to discharge planners, and
So that
so go ask them.
Yeah, absolutely. It started in North Hospital on our medicine floors. And so as we are continuing to refine it and get good feedback, and if it does seem to be successful, which so far we've gotten really good feedback, it is likely going to be throughout the hospital, but it's starting in North Hospital.
So they're hanging in the patient's rooms right now.